Wow. I think we should get started. Let's start on time. So here we go. So we would like to get the program started. So good evening, everyone. This is Nelson Bernardo from the Washington, D.C. area. I'd like to welcome you all to our PMA Washington, D.C. or at Metro Washington, D.C. I guess, what do you call ourselves? Chapter? I mean, what do we call ourselves?
Yeah, we're the
right.
Metro Washington.
Yeah. Hoping to start what we call, I think Nanette wants us to start this expert sessions on different topics with the community, with all physicians, with the PMA and other servers. So anyway, without much ado, I'd like to give the floor to Natalie Kyon, who's the president of the PMAMWDC. Natalie?
Hi, good evening to everyone. Welcome to the inaugural presentation of the Philippine Medical Association of Metro Washington, D.C. Expert Talks for 2021. Hopefully we can continue this for as a tradition. We prepared a very timely topic regarding COVID vaccines, and it will be discussed by our infectious disease experts. We are in the midst of this pandemic, and the only way we can get out of this is through scientific and evidence-based approach. So I welcome everyone to this hour, and thank you for spending this hour with us. It is quite a big audience from not only nationwide in the United States, but also in the Philippines. We also have physicians, nurses, physician's assistants, nurse practitioners, and everyone in almost every level of training. So we welcome you. I'd like to give the floor now to Dr. Amy Belloy to introduce our speakers.
Hello, everyone. I'm Amy Belloy. I feel privileged to introduce the speakers tonight, Dr. Homer Abiad and Dr. Franco Felizarta. They are my esteemed colleagues and classmates from the University of the Philippines College of Medicine. It's been 30 years since we all graduated from the UP College of Medicine. Doctors Abiad and Felizarta have been invaluable sources of information and guidance, and they have helped us navigate the scientific journey and sift through data during this COVID-19 pandemic. Despite their busy schedules, they've been kind and gracious enough to carve their precious time for this activity. Dr. Franco Felizarta completed his internal medicine and infectious disease subspecialty residencies at the State University of New York, Health Sciences at Brooklyn. He's in a solo practice in Bakersfield, California. And Dr. Felizarta is an infectious disease consultant and HIV specialist at multiple health departments and counties in Southern California, and also California Department of Corrections Rehab Telemedicine Program. He's the director of Antibiotic Stewardship Program in Bakersfield Memorial Hospital. He has extensive research experience as principal investigator in 175 clinical trials with 50 publications and abstracts related to the treatment of patients with HIV, chronic viral hepatitis, NASH, and COVID-19. Dr. Homer Abiad has been an infectious disease specialist at Stroger Hospital of Cook County, formerly Cook County Hospital in Chicago, for 20 years. He received his postgraduate training at the Medical Center of Central Massachusetts, the University of Chicago, and University of Illinois at Chicago. He is currently an assistant professor at Rush Medical College. I'm also honored to have Dr. Eric Rains join us for the question and answer portion of this activity. He's a great resource for the local COVID-19 vaccine rollout here in Washington, D.C., Maryland, and Northern Virginia. Dr. Rains is board certified in internal medicine and infectious disease. He's been in practice for 39 years, affiliated with Inova Hospital in Mount Vernon and in Alexandria. And with that, we can get started with Dr. Felizarta. Go ahead, Franco, you have the platform.
Hey, Amy, Franco for a while. So I just want to remind everybody, right, we have a chat room over here. So if you have any questions, just feel free to type it in. Then we'll keep tab of it and we'll ask the speakers after their talks to answer those questions. Okay, just feel free to type in the chat room. Okay, Franco, go ahead. We have to unmute you, Franco.
Thank you for the kind introduction. Can you hear me now?
Yes, yeah, you're good, Franco. Can you share your screen?
Let's see.
You're good, Franco, you're on.
Can you see that now?
Yes, you're good.
Thank you. So thank you for the kind introduction. Good evening to all of you sa mga taga-Pilipinas. Magandang umaga po sa inyo lahat. So tonight I will be discussing the different vaccine platforms, including the advantages and their disadvantages. But before that, let me just review some of the virological, immunological, and epidemiological aspects of COVID-19. So let's start with the virology. So this is the phylogenetic tree of the family Coronaviridae. And the coronavirus has 4 groups, the alpha, beta, delta, and gamma. So the most important groups is the alpha and beta, at least for humans. So the beta coronavirus group has the SARS, the severe acute respiratory syndrome coronavirus, and of course MERS, which is the Middle East respiratory syndrome. And of course the COVID-19 virus, the SARS-CoV-2. It also has these 2 common cold coronaviruses, OC43 and HKU1. The alpha coronavirus has the 2 other common cold viruses, 2219 and L63. Now, 15% of all common colds is secondary to these 4 coronaviruses. You don't get lifetime immunity against these coronaviruses. Most of the immunity is only limited to less than 1 year. For SARS and MERS, the immunity is actually more than 2 years. So we're actually hoping that with SARS-CoV-2, the immunity will last for more than 1 year. So these are the virus host interactions. As you can see here, the primary host for most of the coronaviruses are bats and mice. Intermediate host for the SARS-CoV-2 is probably the pangolin. This is controversial though. Now there's an interesting theory based on an article from the Journal of Virology, February 2005. The theory was that there was an 1890 pandemic in Russia. It's called the Russian flu. And they think it's not from the H2N2 influenza virus, but actually from the human coronavirus OC43. So that actually caused pandemic in 1890. And now it became a coronavirus, a common cold coronavirus. So we're hoping, our hope is after this pandemic, the COVID-19 virus hopefully will become a common cold virus in time. But I doubt it though. I doubt that will happen. I think this will be more similar to the influenza virus where we're gonna have regular vaccinations. So this is the morphology of the SARS-CoV-2 COVID-19 virus. As you can see here, there's the spike protein, the envelope protein, the membrane or the matrix protein is actually the membrane protein, and of course the lipid envelope. The membrane is bound to the nucleoprotein or nucleocapsid, which envelops the viral RNA. Now this is the enlarged picture of the spike protein. As you can see here, there's the receptor binding domain. This one attaches to the cellular receptor ACE2 or angiotensin converting enzyme receptor, which is common in the respiratory tract. Now, most of the antibodies we create are against the spike protein. The rest is against the nucleocapsid protein. So when you are vaccinated against the with the Pfizer or Moderna vaccine, you're gonna create a antibody against the spike protein. Okay, you can actually differentiate between vaccination and natural immunity, because with vaccination, the only antibodies you're going to produce is this antibody against the spike protein. With natural, you'll create antibody to the nucleocapsid and to the spike protein. So for example, the antibody tests we have right now are mostly against the spike protein, like the Abbott antibody test is against the spike protein, and the Siemens antibodies test is against the nucleocapsid protein. So you can actually differentiate vaccination with the mRNA. Now, with the inactivated vaccine, like for example, with the Sinovac, you're gonna produce both, okay? So this is the genome of the SARS-CoV virus. And as you can, this is about 30,000 bases long, okay? So it's longer than the influenza genome. And as you can see here, this is the gene for the spike protein. Now, we've been hearing about all these variants. So there are 3 variants of concern. Now remember, it's normal for the COVID-19 virus to mutate. It's actually about 3 times slower compared to the influenza virus, 3 times slower, okay? I don't know now that it looks like there's an acceleration, but these are the 3 variants of concern. One is the United Kingdom variant, which is the B117, the South African variant, which is the B1351, and the Brazilian variant, which is the P1, okay? Now, all of them share the original mutation from China. This is the D614G, D614G. All of them share that. But the new mutation is the 501, the N501. Why? These are the new, they share this mutation, the N501. Now, the South African and Brazilian has 2 new mutations that are of concern, the 417 and the 484, especially the 484. Both of them has that, okay? The United Kingdom and Brazil are similar with regards to the deletion at 3675, 3677. So actually, if you have a PCR test that's based on this area, you're gonna have a false negative test. You're gonna have a false negative test if you actually use that PCR test against the UK variant and the Brazilian variant. So this is the mutations, the spike gene, the 501 mutation is in the spike gene. In this is for all 3 variants. And for the South African and Brazilian variant, you have additional mutations here, which is 417 and 484. The original mutation from China, the 614, is located here. Now, as you can, this is going back to the spike protein, the location of the N501K mutation is here. And this is actually the receptor binding domain. And this is the one that attaches to the ACE2 receptor. So it actually supposedly enhances the attachment to the cellular receptors in the respiratory tract. That's why it was a concern. So let's go to the immunological aspects. So as you can see here, there are 2 kinds of immunity. There's the initial innate immunity, and then the subsequent adaptive immunity, which is composed of antibodies and the CD4, CD8 T cells. Now, in an average SARS-2 infection, you're gonna have this delayed innate response, and then you still have a subsequent effective adaptive response. That's why the viral load will subsequently go down. However, in severe SARS-2 infection, you're gonna have, this is about 10% of infections, you're gonna have this very delayed innate response, and this is usually neutrophils, macrophages, and interferon, very delayed and ineffective innate response. And also you have this delayed and very low T cell response. So because of this, the viral load keeps going up. And because subsequent to that, the innate response has to overcompensate. So it overcompensates. And this actually causes severe disease. And it's called, the cytokine storm. So really, it's not the adaptive response that overcompensates. It's the innate response overcompensating with an ineffective adaptive response. Okay, so this is the adaptive immunity. We were talking about acute adaptive immunity. Now, after recovery, you're gonna have this immune memory cells. So you still have the antibodies, you're gonna have the memory B cells, memory CD4 cells, and CD8 cells. So according to this study by Dan and his colleagues in Science, published in 2021, the spike, the IgG immunoglobulin to the spike protein is relatively stable for 6 months. So this is this contradicts the initial studies that the half-life for the immunoglobulin, the antibodies, is about 3 months. Also, the spike-specific memory B cells were more abundant at 6 months compared to 1 month. So it means there's really no half-life. There's a possibility that the memory B cells will be for life, okay? The SARS-CoV-2 CD4 T cell now and CD T cell memory cells has a half-life of 3 to 5 months. So this is good news. There's a possibility that there will be lifetime immunity. Of course, we'll be happy if the immunity lasts for more than 1 year. Now, the problem of the variants, though, the variants, for example, especially the Brazilian and the South African variant, they actually would affect the existing monoclonal antibodies and the convalescent plasma. So you can actually have an increase in reinfections. So I'm going to give you an example. In Manaus, Brazil, in the first, they had the first wave, I think during the summer, 75% of the whole population of Manaus got infected. So they actually achieved herd immunity. But now they're actually having a severe secondary wave, a severe second wave. So it means, if this is true, that there might be a lifetime immunity, it means the Brazilian variant eluded the original immune response. So that might not be good news with the new variants. Epidemiological aspects. So mortality-wise, this study is showing us that a larger share of the US population died in the first 9 months of 2020 than any past 50 years. Of course, the mortality rate has been declining in the last 50 years because of health-related improvements. But as you can see here, there's a 40% increase in deaths because of the 1918 pandemic, 40% increase from the previous year. But with COVID-19, it's more than 15% compared to the previous year. So we haven't seen anything like this except with the influenza epidemic in 1918. This one is also showing that during the first wave of the COVID-19 epidemic, it became the #1 cause of death in the United States, more than heart disease and more than cancer. And in the third wave, it's not shown here, we know the third wave is even worse than the first wave. In terms of excess deaths by age groups, as you can see here, there's actually no, it's quite uniform. The excess deaths is quite uniform from 25 to 44 to more than 85 years, quite uniform. So the excess deaths, even in patients who are 25 to 44, is just less pronounced in less than 25 years old. Now, infant mortality rate really depends on the age. So it actually, COVID-19 follows the Gompertz law of mortality, G-O-M-P-E-R-T-Z. This is when there's an increase of 10% for every year, and the mortality rate doubles every 7-year difference. So for example, in a 90-year-old, the infection mortality rate is about 20%. For a 20-year-old, it's about 2 in 10,000. It's 1,000-fold difference, 1,000-fold difference. So age is very important. So for example, the infection mortality rate in Malawi, where the median age is about 15, will be probably 0.1. The infection mortality rate in Japan, which has a median age of about 45, would be probably 1.6%. That will be 16 times higher than Malawi. Okay, this is just based on age alone. However, you still have to adjust it by health system capacity. So if you adjust it by health system capacity, of course it will increase. For example, in sub-Saharan Africa, the IFR will be 0.1 with, if you adjust it, it becomes 0.4. In the Philippines, in Southeast Asia, it will be 0.3 to 0.9. Of course, Philippines has a younger population than most Southeast Asian countries. It's probably gonna be 0.2, and with the adjustment with the health system capacity, it will be up to 0.6. United States is about 0.8. So let's briefly discuss 4 epidemiological parameters of SARS-CoV-2. This is the basic reproduction number, which is about 2.5, the dispersion coefficient of 0.1, the incubation period of 5 to 6 days, and the serial interval of 4 days. So basic reproduction number, initially, we thought it will be 2 to 3, but now it looks like it's gonna be 3 to 4. And with the new variants, remember the new variant, especially the UK variant, is 50% more transmissible than the original variant from China. So it looks like it's gonna be 4, the reproductive number. Of course, the mortality is between 0.5 and 1%. So herd immunity is really based on their basic reproduction number. So for example, if it's gonna be 4, that's 1 minus 1/4, 1 minus 0.25 is gonna be 75%. So the herd immunity looks like will be 75% of the population has to be infected or vaccinated to achieve herd immunity. The problem though is the overshoot, okay? So even if you reach the herd immunity, let's say 70%, you're still gonna have people getting infected after that point. So you're gonna have this overshoot where people kept getting infected after the herd immunity is reached. So from 70%, ultimately almost 90% will be infected anyway. So that's almost the whole population. I mentioned the dispersion coefficient. COVID-19 has over dispersion, meaning there's a lot of super spreaders. Okay, so in this study by Goyal, 10% of infected individuals contributes to 85% of the transmission. 10%. It means about 50% will not even transmit it to another person. So it's mostly super spreaders, about 10% of the population. Influenza, they have equal contribution. There's not much super spreading events with influenza. So in this study in Nature, they've shown that most of the super spreading events are in full service restaurants. Full service restaurants is number 1 because of super spreading events. And this is actually quite, this is consistent with the risk of airborne disease comparing indoor and outdoors. So it's actually 30 times higher with indoor activity compared to outdoor activity. You can skip this. Okay. So incubation period is, remember, is 5 to 6 days. Serial interval is 4 days. The most important thing to remember here is the serial interval is shorter than the incubation period. It's because of the pre-symptomatic transmission, meaning there's this 1 to 2 days where you don't have any symptoms before you become symptomatic. And of course, when when you have symptoms, you have more contacts. And that's why 45% of this transmission is pre-symptomatic. It's very hard to stop COVID-19 because you have this pre-symptomatic transmission where you can transmit COVID-19 1 to 2 days before you become symptomatic. So now let's discuss the vaccine platforms, okay? So remember, the traditional timeline for vaccine development is usually more than 10 years, okay? And for example, varicella, it took 28 years. For rotavirus, it's 15 years. Our goal initially is to have it in 18 months. And it's miraculously, we actually did it in 10 to 11 months. How did we do it? It's because most of the phases, phase 1, phase 2, phase 3, and even the large scale production was done almost in parallel. Usually we finish phase 1 first, then phase 2, and phase 3, and then we begin large scale production. During the COVID time, we did this almost in parallel, okay? So there are 8 platforms for the COVID-19 vaccine. So There's the virus vaccines, there's the inactivated, live attenuated, the viral vector vaccines where it's replicating and non-replicating, the nucleic acid vaccines, you have the RNA, the DNA, and the protein-based vaccines. So they have the protein subunit and the virus-like particle. So let me give you an example. Inactivated, we have, these are the leading vaccines right now. Inactivated is the Sinovac. Non-replicating, we have three. We have the AstraZeneca, Johnson & Johnson, and the Russian vaccine, the Gamaleya. The nucleic acid vaccines, we have two RNA, which is the Pfizer and the Moderna. And for protein-based, we actually have Nanovax, which is more of a virus-like particle. So let's discuss the each platform. So we can skip this. So inactivated virus, it's pretty straightforward. You know, of course, it doesn't replicate, and it's presented to the antigen presenting cell. It's taken up, and then it induces immune response. That's for the inactivated. Now, for the non-replicating viral factor, so this is the Johnson & Johnson. The inactivated previously is Sinovac. This one example is Johnson & Johnson, AstraZeneca, and the Russian vaccine. They use a viral vector. It's used for adenovirus. Okay, so you have this recombinant gene of the coronavirus spike gene, and it's combined with the adenovirus gene. So, for example, AstraZeneca uses a chimpanzee adenovirus. The Russian chose two kinds, the adenovirus 26 and adenovirus 5. And the Johnson & Johnson used adenovirus 26. The problem with adenovirus is it's a common cold virus. So most of us, well, actually not most of us, but a significant portion of us will have a lifetime immunity against the adenovirus. So the problem is the adenovirus 5. Adenovirus 5, more than 50% of the population will has immunity against it. So the Russian vaccine solved this by adding adenovirus 26. Johnson Johnson only has adenovirus 26. And of course, AstraZeneca uses chimpanzee adenovirus, which of course, there's really no immunity against that in the human population. And then of course, the nucleic acid vaccines, these are we have the RNA vaccine, which is the prime example is Pfizer and Moderna. And instead of using a viral vector, they use a lipid coat encasing the RNA. And this lipid coat is done using nanotechnology. So, and they use the lipid coat because it can easily enter the membrane, the cellular membrane. So protein subunits are either spike proteins, separate spike proteins, or virus-like particles. So virus-like particles are empty virus shells that mimic the coronavirus structure. The Nanovax is quite different though. I think in between the two. It's actually composed of spike proteins, but using nanotechnology, they made it mimic the coronavirus structure without an empty virus shell. So let's discuss the advantages and disadvantages of the platform. So for example, for safety, right now we don't have any live attenuated virus vaccine, so we don't have to discuss this. For inactivated virus, there's some concerns for safety because it's a dead virus. All of the others should be safe. Speed and ease of production, of course, the fastest will be the RNA viruses. And in terms of logistics of global distribution, though, there's a problem with the RNA. So for example, for Pfizer, it needs to be frozen at -70. And for Moderna, it needs to be frozen at -20. So it becomes a logistical nightmare with mRNA if you don't have the freezers. The J&J virus, though, should be only be refrigerated like the Sinovac. In terms of potential for neutralizing antibody production, supposedly the non-replicating virus vector and the mRNA is weak. But if you look at the phase 1, phase 2 data for J&J and the Pfizer and Moderna vaccines, they actually have a good induction of the neutralizing antibody. Cellular immunity, this should be good for the RNA vaccines, poor for the inactivated virus, and poor for the soluble or nanoparticle like the Nanovax. But when you look at the phase 1-2 study for Nanovax, it actually showed decent cell-mediated immunity. You can skip this. Actually, let me just discuss this. This is the SA self-amplifying RNA. This will be the future of vaccines, because you can actually give a smaller dose than the mRNA because it actually can amplify by itself. So they actually added a RNA polymerase together with the spike protein so that they can amplify the mRNA. So this is my last slide. So showing the comparison in terms of efficacy. So Homer will discuss this later on. So for Pfizer, the efficacy is about 95% based on the phase 3 study. Moderna is about 94.5. So, you know, this is essentially the same. The Russian vaccine reported to be 91.4%. However, this is unpublished. You know, so we don't have, this is based on the phase 3 study, but unpublished. AstraZeneca, of course, this was published. It's from 62 to 90%. It's quite confusing because there was a difference in the age of the, there's 4 trials, separate trials, United Kingdom, in Brazil, South Africa, and United States. And each has a different dosing. Some of them are half dose. Some of them were only given to less than 50 years old. And there's actually differences in the spacing between the 2 doses. So some of them are 4 weeks apart and some of them are 12 weeks apart. So in general, when the spacing is longer, the efficacy is actually better in general for vaccines. So for Pfizer, it's 3 weeks apart. For Moderna, it's 4 weeks apart. For the Russian vaccine, it's 3 weeks. For the AstraZeneca, it's 4 weeks. Sinovac is 2 weeks. And Novavax is 3 weeks apart. Johnson & Johnson is the only one with 1 dose. So this is quite an advantage for Johnson & Johnson. They don't need a prime boost, 2 doses. Now, there's no phase 3 trials. J&J is supposed to have the phase 3 results next week. So hopefully that would be more than 90%. Novavax probably will have theirs in February or March. Sinovac, the reported efficacy is 50%. And this is based on the Brazilian trial in about 13,000 patients. So that's not much. You know, for example, Pfizer has 40,000 and Moderna has 40,000. So this one was based on 12,000 patients. There was a report of 90% in Turkey based on 1,300 patients. And there was a report of 70% in Indonesia based on 1,600 patients. So, you know, that's the problem. They're all unpublished, but my suspicion is the difference is because of of course, not small number of patients, and there's actually differences in the spacing between the 2 doses. So usually it's supposed to be 2 weeks apart, but some of the trials are 3 to 4 weeks apart. And in my opinion, though, spacing of 2 weeks is too short especially for inactivated vaccine. So hopefully they will have a better data with 3 weeks or 4 weeks of spacing. Thank you.
Thank you, Dr. Franco. Nelson, yeah.
Yeah, thank you, Franco. Hey, Omer, you want to start on your talk? Share your screen. I don't see it yet, Omer. Yeah, we got it. You got it, Omer. Go ahead. Thanks.
Thanks for that great overview, Franco. Franco and I have been classmates in high school and college and med school, and it's always been a wellspring of knowledge and data. My task tonight, though, is more of the just focusing on the vaccines that we have here and now in the US. And so I'll launch into that. I have a lot of information, so I'll be going a little fast. So basically, as everyone knows, we have two vaccines now. They're both mRNA virus vaccines. They're both under emergency use authorization by the FDA. The Pfizer BioNTech vaccine got its EUA in December 12, and a week later, the Moderna vaccine got its EUA. Here, this one is just to compare the two. They're both mRNA vaccines. Both had very large phase 3 clinical trials. And as Franco mentioned, on very, very good efficacy. It's really been amazing, 95%, 94.5. Maybe one of the big differences, practical differences, is the age group. Pfizer was studied and is approved for 16 years and above. Moderna is for 18 years and above. Again, both are 2 doses given IM. The Pfizer's given 3 weeks apart, and Moderna is 4 weeks apart. As Franco mentioned, logistically, Pfizer's a little trickier. You need ultra low temperature freezers, minus 75 degrees, while Moderna is just minus 20 degrees, which is the temperature of a regular freezer. So logistically, again, even here in the US, Pfizer is more in the large medical centers that have these ultra low temperature freezers. Obviously going to be a bigger problem, especially when you get to low and middle income countries abroad. Stability after thawing is also a little more difficult with Pfizer. It's just once you thaw it and keep it in the refrigerator, it's just good for 5 days. The Moderna vaccine is good for 30 days. Again, it's a little more practical that way. The Pfizer vaccine does need dilution. The Moderna vaccine does not. Both of them, though, once they're out of the refrigerator, they're only stable for 6 hours. Again, so generally, at the end of the day, yeah, we're always trying to find, extra people. If we have extra doses, we will try to find extra people to vaccinate because basically those are spoiled. You can't use them the next day. Contraindications, sort of standard history of severe allergic reaction or anaphylaxis or immediate allergy to the first dose of the vaccine. So if you have a severe reaction to the first, obviously you can't get the second, or to any component of the vaccine. And the EUA information has all these components. Generally, it's felt that the anaphylactic cases that have been found are most likely due to polyethylene glycol that you have in both of these vaccines. Anyone who's had a colonoscopy or has ordered one knows polyethylene glycol as Go Lightly, which is used basically as a bowel prep for a colonoscopy. It's present in a lot of cosmetics and medications, even over-the-counter medications. Allergies are actually fairly unusual, but have been well described. And it's felt that the people who do have anaphylaxis to these 2 mRNA vaccines are because of these polyethylene glycol. Similarly, history of immediate allergic reaction to polysorbate, that's another chemical that cross-reacts with polyethylene glycol, is a contraindication to either of these vaccines. The safety is really very good. We have very good short-term safety data, but of course, we're still awaiting long-term safety data. Both vaccines are reactogenic, so they're very common mild side effects that reflect the brisk immune response that they generate. Again, mostly a local injection site pain, fatigue, headache, myalgia, chills, arthralgia, and joint pains, and fever in a small minority. These side effects usually develop in the first 1 to 3 days and really generally resolve within 24 to 48 hours. They are more frequent in tend to be more severe in younger people, and also after the second dose. So myself, I got my second dose 2 weeks ago. It was scheduled on a Monday, but I had a busy clinic day the next day. So I moved it to Friday because I was afraid if I got any of these side effects, I didn't want to be in clinic that day feeling bad. So luckily everything went well. So safety, again, there have been, as everyone knows, it's been in the news a lot, there have been a few cases of anaphylaxis, most but not all in people with history of allergies. A majority occur in within 15 minutes, the median's 13 minutes. For Pfizer, there have been 45 cases so far. So that comes to a total of 6.2 cases per million doses. For Moderna, it's been 15 cases, which is 2.1 cases per million doses. As a comparison, the shots, usually about 1.3 cases per million doses. And the measles containing vaccines range from 3.5 to 10 million cases per dose. So the mRNA vaccines are somewhere in that range. So what do we do if for people who have a history of severe allergic reaction to other vaccines or to penicillin or to peanuts? They can receive the vaccine with caution, but they're monitored for 30 minutes instead of the standard 15 minutes. What about pregnant and lactating people? Can they get the vaccine? They can get the vaccine, although again, we don't really have good data. However, pregnancy is a risk for severe illness from COVID-19, so it should be offered. They should just be aware sort of like the risks, the benefits, and again, the unknown. We don't really have data, but there's no theoretical reason that the mRNA vaccines should be harmful, and they've been safe in animal studies. Immunocompromised patients are at risk for severe illness from COVID-19 and so should be vaccinated. It's not the contraindication. Actually, it's more of an indication, although there's the caveat that the vaccines may be less effective because of a weakened immune response naturally. Guillain-Barré is not a contraindication. There have been no reported cases among vaccinees, and history of Bell's palsy is also not a contraindication. There were cases reported in both trials, but this wasn't considered above the frequency in the general population. What about patients who've had COVID? Can they get or should they get vaccinated? Yes, natural infection with COVID does provide immunity, but it's felt that the vaccination will actually provide longer lasting immunity. So those who've had COVID in the past should be vaccinated, although it's felt that they can likely wait 90 days because the reinfection rate is rare within 90 days. However, if they received convalescent plasma or monoclonal antibodies, these are felt to potentially interfere with the immune response. So if they received either of these, then you should delay your vaccination for 90 days after they receive these treatments. Someone currently with COVID, can they be vaccinated? Obviously, you want them to recover first and complete self-isolation before they can get the vaccine. And again, they can likely wait 90 days. Post-vaccination monitoring, so after you get your shot, you're observed for 15 minutes routinely, 30 minutes for those with history of severe allergies. Vaccination sites should have epi, antihistamines to treat anaphylaxis as well as less severe reactions. The minor side effects that are very common can be treated symptomatically with acetaminophen and NSAIDs. The CDC, though, advises against giving them before the vaccination. So do not give them preemptively because it's felt that potentially it can, the anti-inflammatories may cause problems with the immune response. Then you get your vaccination card with a lot number. You've probably seen a lot of these on social media posts. And on the back, it's just a reminder of the second date for your second vaccine. EUA fact sheets, we're used to getting vaccine information sheets for vaccines, but since vaccines are not fully FDA approved, there's no VIS, just this EUA fact sheet that given to patients, as well as these sheets for vSafe. What's vSafe? vSafe is a smartphone app for reporting adverse events directly to the CDC. Enrollment is not mandatory, but it's encouraged. And definitely, I'd encourage everyone who gets the vaccine here in the US to enroll in this, because this is how we get robust data on side effects. So basically, you enroll in this, and then on your smartphone, these are screenshots from my phone, basically daily for the first week, and then weekly after that, you get checks. How are you feeling today? Do you have fever? Do you have any of these symptoms? And basically that's reported directly to the CDC. Severe adverse effects are reported as is standard through the vaccine adverse events reporting system. And they're reported whether or not they're attributable to the vaccine. The scheduling of the second dose, again, for Pfizer, it's 3 weeks. Moderna, it's 4 weeks. It's recommended to give it in that interval, but if it's not possible, you can delay by a few days. Again, mine I took at like 25 days instead of 21 days. Better delayed than early, but again, it's give as soon as possible after the missed scheduled dose. If absolutely necessary, say someone's leaving the country and a little early, and they need to get their second dose. The dose can be given a little early. There's a 4-day grace period, but again, it's recommended, if anything, to give it later if you can't give it exactly on the recommended interval. The vaccines are not interchangeable, so if you got your first dose of Pfizer, your second dose should be Pfizer, and likewise for Moderna. Most places, including where most of the audience right now in Metro Washington, DC, are currently in phase 1B, which is generally 65 years and older, essential workers such as teachers, firefighters, law enforcement, although this varies from jurisdiction to jurisdiction. So like this one here is a graph for the Fairfax County. Basically, there are sort of everyone's doing it their own way, so you have to check with your local jurisdiction. Just a few questions that we often get. Can I choose which vaccine I will get? Generally, no. Each vaccination site will currently have only one of the two vaccines. So at one hospital, generally, they'll just be giving one or the other. So right now, yeah, generally take what you can get. How long after vaccination does immunity develop? Generally, in the studies, in the phase 3 studies, 10 to 14 days after the first dose, they were seeing a difference already compared to placebo. And full efficacy, we see at 7 to 14 days after the second dose. How long will immunity last? Again, we don't know for sure. Neutralizing antibodies have been found at least for 4 months, but then probably longer than that. It's unclear how long cellular immunity will last. So again, the first phase 1 trial started March of last year. So we're having people who are getting towards 1 year. So soon we'll have sort of better longer term data about immunity. And then finally, now that I've been vaccinated, can I stop wearing a mask? No, unfortunately, we need to continue practicing social distancing, hand hygiene, mask wearing, avoiding crowded indoor settings. Again, the studies were looking at prevention of symptomatic treatment, particularly for Pfizer. So we don't really know if they protect against asymptomatic infection. We'll have some data from that. Moderna actually was doing some PCR testing, but particularly for Pfizer, we don't know. Effectiveness isn't 100%. And then part of this also is sort of a social contract. You can't have some people saying, I got my shot, I'll go out without a mask, and the others who haven't gotten their shots have to wear the mask. Sort of, we're all in this together. We should sort of be wearing masks all together until such time that community transmission is really dropped down, and then all together sort of we'll be able to say, okay, we can sort of public health authorities will have to be able the ones to say, okay, we can stop doing this, we can ratchet down our mitigation measures. And I will stop there because again, just we're all in this together, and I will stop here so we can leave some time for questions. Thanks very much.
Thank you, Dr. Felizarta and Dr. Abiad. Great talks. So I think we have time for some questions. I think I'm going to hand to my co-moderator, Dr. Erwin Puente. Erwin, you want to take over for the questions?
Yeah, thank you guys for those wonderful talks. There's one first question from the audience was directed to Dr. Rains. If a person has tested COVID positive and it has been more than 90 days, however, the patient still has some lingering COVID symptoms, the quote COVID long hauler, do you advise that they still get the COVID vaccine, or should they wait till they completely recover? Or if they do get the vaccine, will that just worsen their lingering symptoms?
I don't think we have enough data to say that, but I would recommend getting the vaccine if you have low-grade symptoms that far out. We don't have, I'll ask the doctors to chime in, we don't have a lot of data on this post-COVID infection sequelae. It happens, fatigue, cough. One of my colleagues is doing a study on post-COVID pneumonia PFTs to see if there's a long-term fibrosis, a long-term physiologic effect. But my answer would be, in short, go ahead and do it. What we really need in those cases is a viral load, which is not commercially available yet. But if you can get a viral load and the viral load is undetectable, then it's certainly safe.
Okay.
Good. Any comment there, Omar or Franco? Omar?
No, from my standpoint, yeah, I think again we sort of, so this certainly is a problem with these long haulers. Although, yeah, it's really not felt to be due to ongoing infection, and certainly I think vaccination at that point, from my standpoint, should be all right.
Okay, good. Thanks, Dr. Rains, Omar. Hey, I think Dr. Bustos has a question that you want to ask live. I don't know if he's on. Erwin?
Yeah, good evening, everyone. I just have I was sharing earlier with Nelson, I had an interesting case in a nursing home. She's an elderly 87-year-old woman who developed COVID back in October. So luckily she recovered from that. She received 2 vaccines, 2 doses. I think it was Pfizer. Completed like 2 weeks ago. Then she was transferred she had a COVID test and they were all negative. You know, in a nursing home, you get tested every week or twice a week, especially for workers. 2 tests had been negative, then we had to transfer for bleed for transfusion. Didn't stay much in the hospital. Came back. This time they tested her again. It was positive again, and this is 2 days, 3 days after having the vaccine. I do understand from Dr. Abiad takes 7 to 14 days. That was one of my questions: how soon before be effective? But the question I have also is, can you have a false positive test? That's number one. Number 2, can you continue to be a carrier, because some of the same nursing home resident had been vaccinated, but can you be a carrier despite getting a vaccine? I think this is very important clinically, because a lot of our patients live with the elderly, and I just want to get your answer regarding this.
Okay. Omar, you want to tackle that?
Sure. So it's a number of aspects there. One, I guess the one question is, for instance, can the vaccine affect your testing later? Certainly, the vaccine, so the mRNA vaccine, for instance, can affect your antibody testing, but should not cause, say, false positive PCR, a molecular test, because those are really looking for the virus itself. in this case, the question, the second aspect is the question about do the vaccines prevent can you have asymptomatic carriage? Again, we don't know. Again, we'll have more information from the Moderna study, but again, certainly for Pfizer, it wasn't looked at. They only were monitoring for symptomatic disease, so we don't know exactly if certainly if the Pfizer vaccine prevents asymptomatic carriage. Franco, you have anything else to add?
Yeah, at least for symptomatic transmission, 2 weeks after the first dose, there's already a 50% efficacy. And if we look at between the second dose and before the 7th day after the second dose, it's already 90%. So it's actually maturing. That's why there's actually a case for just giving 1 dose. It matures from 50%, it actually reaches 50%. And then if you add the second dose, 2 weeks after, increases to about 95%. So it's actually quite effective even after the first dose. It just takes a while. But for asymptomatic transmission, though, we only have data from Moderna, which is like 0.3% in patients on placebo. These are asymptomatic, and 0.1% in patients on the vaccine. So that's a 70% protection for asymptomatic spread. But these are small numbers of patients. Plus, we have to wait for the seroconversion data. They're going to check the antibodies.
Good, thanks, Frank. Dr. Rains, one question here. Is there a role, or is it practical, economically, or the healthcare system of measuring titers before we do anything, before vaccination, or saying, oh, you're safe, you got titers?
Well, it's an interesting question. I'll answer it 2 ways. I think economically, it's not feasible. I was part of a study testing healthcare workers and antibodies, and I was positive. And I got my vaccine about 60 days later. So I don't think having a positive antibody should not stop you from getting a vaccine.
Okay. And I agree. We don't really know yet what the correlates of immunity are. And exactly for the antibody, for instance, even if we could, quantitate them very reliably, what level is protective? And so one of the registrants also asked, should I get tested after I'm vaccinated? So right now there are no recommendations because we do not know yet, exactly what would be protective anyway. Hopefully down the road we would have that. For instance, like hepatitis B, sort of we can tell we have sort of a level of antibodies where we can say now you're protected or your levels have dropped. But right now we don't have that for the COVID vaccines.
There's some good data, though, at least for the Moderna vaccine. They've shown that the neutralizing antibodies 4 months after the vaccination with Moderna vaccine is higher than that of a convalescing patient at 30 days. So 4 months versus 1 month, and still the neutralizing antibodies are higher. So right. At least at least that's good news for Moderna. We don't have any data right now for Pfizer.
Right, and those are the studies as well that justify the recommendation for people to get vaccinated, even if they've had natural infection.
I agree.
Yeah, there's another question sort of going along with that is, should I be concerned if there was no detectable antibodies 3 weeks after the first dose of a vaccine, like a Moderna vaccine?
So remember, when you have the Moderna or Pfizer vaccine, you're going to make an antibody against the anti-spike protein. So you better make sure that the antibody test will actually detect the anti-spike protein. So for example, I'll give you an example. The Siemens antibody test will only check the anti-nucleocapsid. So if you have a vaccination, you check with the Siemens test, it will be negative. It will be negative. So you have to be very careful with those antibody testing.
Okay. Good. I think in the interest of time, it's on but 8:59. So I'd like to thank Dr. Eric Rines, Dr. Franco Felizarta, and Dr. Omar Abiad for spending his time with us and educating everybody. And I think we'll end the session with Erwin Puente. Going to give the last, and then we'll close the session down.
Yeah, thank you everybody for coming today. I hope this was very informative. It was extremely informative for me. Love to give many thanks to all the speakers today. And thank you for everyone who helped organize this. We'll be sending out a survey after the program, just giving your thoughts if you have any other questions, and if you have any other topics that you want to discuss in the future.
Okay, with that, in behalf of Natalie Kion and the rest of the officer of PMA, Metro Washington, D.C. area, thank you and hope to see you on our next session on Expert Talk 2021. Maraming salamat. Magandang gabi. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you.
Bye all.
Thank you, everyone.
Thank you.
Bye, Jonas.
Nanette, are you still on?
Yes, I am.
So I think
maybe we can have a meeting.
We should go to a breakout room so we can sort of assess for the evening.
Yep.
Don't you think so?
Yes. Yes.
I can.
How do I do that?
Breakout room.
I'll.
Thank you, everyone.
So
I'm going to officially close the meeting.
Then June, you want to break out room or?